No.
Okay, sir.
And we can start the meeting.
Yeah. Okay. We'll wait for 5 minutes, ma'am. Shall we wait?
No, if we are live, I think maybe we'll start, and
Yeah.
when sir comes in, we can welcome him, and you can.
Okay, ma'am. Okay.
Yeah, but you start introduction of the speakers and all that.
Yeah. Okay, ma'am. Good evening, everyone.
Good evening.
I'm Dr. Santoshini. I'm Dr. Santoshini. I'm growth representative from Telangana Orthopedic State Association. As you all know, growth is group of rising orthopedic women of Telangana in harmony, which was given by our dear Rujuta ma'am. She has suggested the name. And I'm EC member for TOSA also. I am very privileged to host this session, and I'm very glad that we are conducting second growth webinar. And I would like to welcome Dr. Rujuta ma'am, who is the founder of WOICE all over India, and she is very encouraging to everyone. Ma'am, few words from your side.
So I think I'm merely really just a vehicle. You all girls were brilliant anyway, and you have a wonderfully supportive president, and Dr. Vijay Bhaskar has just joined us. So I think that is where things really blossom, when you have a good synergy between colleagues, seniors, and mentors. So I think I want to listen more rather than speak today. So over to Dr. Purgam for some welcome message.
Welcome, sir, Dr. Vijay Bhaskar, sir. Sir is past President TOSA, ma'am. Sir, please, few words from your side, sir.
Yeah, good evening, all of you. Welcome to the webinar.
Good evening, sir.
It's definitely useful to young orthopedic surgeons, especially women orthopedic surgeons. And I congratulate all of you, and then let us go ahead.
Okay. Yeah, I would like to introduce our beautiful speakers for today. First is Dr. Suchitra Gopinath ma'am. She has done her MBBS from Bhaskara Medical College and MS Ortho from Gandhi Medical College, Hyderabad. And she has done her fellowship in pediatric ortho and neuromuscular disorders from Ganga Hospital. And she is now senior fellow at Royal Hospital for Children in Glasgow, UK. Ma'am is talking about today Monteggia fracture, her experience. Ma'am, without further ado, we'll start the session. Please, carry.
Thank you, Santoshini. I would like to first thank Rujuta ma'am for actually starting WOICE and also giving the wings for growth to start up in Telangana. It makes me immensely happy, and I'm truly humbled by the opportunity that I've been given today. I would like to share my case experiences of Monteggia. I'm currently working as a senior clinical fellow in pediatric orthopedics in Royal Hospital for Children in Glasgow. This is a major trauma center in the UK. So I've had the privilege of seeing a variety of pediatric trauma here. I've also done a bit of pediatric trauma in Ganga as well. So one of the cases that I would be discussing, I would be taking inspiration from my previous mentors, Dr. Venkata sir and Dr. Rajshekharan sir as well. I hope everybody can see my screen.
Yeah, ma'am, you can carry on.
Thank you. So I would like to first discuss the case. She was a 3-year-old girl, initially brought to a secondary referral center with concerns by mom of some lump over the anterior aspect of forearm. And the A&E consultants in the secondary referral center had given us a ring saying that the child is completely asymptomatic. This is their second visit to A&E with similar complaints, but they could not really localize any acute symptoms. They thought initially it was probably a pulled elbow, and they performed the pulled elbow maneuver and sent the child home, only for them to come back, unfortunately, with similar presenting issues. When we saw her, she was completely asymptomatic, very, very active child. She had a full range of elbow flexion, extension, and pronation, supination. There was no pain, no tenderness, no signs of any swelling or acute symptoms. But in comparison to the other side, her valgus carrying angle was slightly increased. So this was the X-ray that I was presented with when I received the referral from the secondary referral center. And it was thought initially to be a pulled elbow. And we got a full length X-ray of the forearm done, and it shows that the radial head is dislocated. But apart from that, something which is slightly innocuous in this X-ray, which is not as obvious to the eye as what the radial head is showing us, is that the posterior border of the ulna is not in a complete straight line that we would expect it to be. Why is this important to us? So if I discuss, I'll be discussing two lines here. One is the Mubarak-Lincoln line, and the other is Torrance line. I'm sure everybody knows about the Torrance line and why this is relevant to us in our clinical practice, especially when we're dealing with pediatric elbows. So if we draw a line passing through the center of the radial neck, it should intersect the capitulum in all views, be it in flexion or in extension, be it in AP or in lateral. The Mubarak-Lincoln line is necessary for us to mandate whether the posterior border of ulna is straight as it appears and it should appear to be, or has there been some kind of plastic deformation. In children, this is a common injury, unlike in adults where they completely fail and they come with a dislocated radial head with a fractured ulna. But in children, because the bones are shaped like this and they have a very thick periosteum, we anticipate plastic deformations and green stick fractures, which even though they appear innocent, they can actually end up presenting with such chronic dislocated radial heads. This is important for us to understand because unless we treat the deformity in the ulna, it is kind of hard to restore the radiocapitular alignment. The need for full-length AP forearm and lateral cannot be stressed upon more than this when it comes to Monteggia and pediatric. It's also important for us to rule out congenital radial head dislocation because she was only a 3-year-old child, so painless, so asymptomatic. It's always best to get X-rays of the contralateral elbow, and that is for two reasons. Congenital radial head dislocations, even though anterior dislocations are quite rare, we cannot completely rule out the possibility of it. And the second reason is when we have slight suspicion whether the radiocapitular alignment is in line, we can always take the contralateral X-ray for us to have a better evaluation and probably arrive at the right diagnosis. In this child, the contralateral elbow X-ray was normal as expected. So this turned out to be a chronic Monteggia fracture dislocation. On prodding further about the history, we understood that the child probably had a seemingly innocuous fall from a chair and fell directly on her hand, and the hand went into, and the elbow went into extension. The parents don't really remember taking her to A&E because the child was not complaining a lot of pain, and she was seemingly okay in about a week or two. The two important people that I would like to mention while we are talking about Monteggia is Monteggia himself, who came up with the condition of Monteggia fracture dislocations, and the other person that needs to be recognized when we talk about Monteggia lesions is Bado, who has given us the classification for Monteggia lesions. He's in fact written a complete book on Monteggia lesions. So if we come back to the classifications, it's Bado's, and we also have a modified a classification which takes its inspiration from BADO. It's called as LETS, and this can be used in pediatric age group. There are 4 types of BADO's Monteggia lesions. The first one, where there is anterior dislocation of the radial head with an anterior apex of the ulnar fracture, posteriorly angulated ulnar with posterior dislocation of radial head, and a lateral dislocation of the radial head with a lateral fracture of the ulna. And type 4 is where there is concomitant fracture of radius as well as ulna. Type 2 is quite rare, but type 1 and type 3 can be commonly seen. LETS has given a similar classification in children, where type A, B, and C are basically type 1 BADO, but in type A there is plastic deformation. In B and C there is a green stick fracture, and C where the green stick fracture has progressed to an anterior complete fracture. And type D is basically a type 2 BADO, and type E is basically a type 3 BADO. If we just look into the mechanism, the most plausible explanation for Monteggia mechanism has come from Tompkins, and he describes 3 stages for this. The first stage is where the elbow goes into a state of extension, and there is a reflex contracture of the biceps when the elbow goes into extension, and the radial head is anteriorly dislocated. And we know that radius takes about 80% of the load through the forearm to the carpus. And so when the radial head gets dislocated, ulna becomes the sole weight bearing bone, and it fails in tension. Most of the fractures that you would see in Monteggia are oblique fractures because they fail in tension. So what can be the problems that we encounter in chronic Monteggia? If we think of it, a lot of literature says that there can be a radial head hypertrophy. The concave articular surface of the radius can end up becoming convex, and there can be an increase in valgus carrying angle. When can we operate on chronic Monteggia? So when we go into the literature and look at it, the most commonly cited criteria and widely accepted criteria is when the radial head has been dislocated for less than 3 years and the age of the child is less than 12 years. Although the literature also states if there has been no hypertrophy of the radial head, irrespective of the age and the number of years that the radial head has been dislocated, these patients can end up having good results and have a good prognosis if they undergo surgical intervention. Whether we should repair the annular ligament or should we reconstruct? So this paper by Delpont states that a proximal ulnar osteotomy associated with annular ligament repair, and they have compared it to children and patients who have had a proximal ulnar osteotomy with annular ligament reconstruction, and it was found that ligamentoplasty did not have greater benefit, and annular ligament repair in the setting of an ulnar osteotomy with overcorrection seemed to give good results. So what are the most important things that we would be addressing in this case? As we could see, that was a LETS type A, where there was a plastic deformation of ulna. So we'll need to correct that. We'll need to restore the length. And if need be, we have to overcorrect the angulation of the ulna to make sure that the radial head falls back into its alignment with the capitulum. We have to reduce the radial head and also check for its stability and address the annular ligament based on the intraoperative findings. So our scheme of events went like this. We went through the Boyd's approach and we did the ulnar osteotomy as per Rajshekharan et al. So this is a sliding Z-shaped osteotomy. And in the original paper that's described, there was a single screw fixation, which allowed for angulation and the site of angulation to be fixed with a single screw. This gives you the benefit of maintaining good contact between the proximal and the distal fragments of the ulna, because there have been a few cases that were reported after the ulnar osteotomy. There was non-union of the osteotomy site. This kind of an osteotomy gives you a good contact area, good bony apposition, and it differs the chances of non-union. So in our case, despite doing the osteotomy, the radial head was unstable. We opened the radiocapsular joint, recapitular joint. There was a lot of interposed tissue in between. We had to remove that. We tried to fit the radial head through the annular ligament by making few radial tears as described by Dr. Mollinshaw in one of his lectures and discussions, but somehow that didn't help as well. So we had to repair the annular ligament, and we had to also stabilize the radial head temporarily with a K-wire while we fixed the ulnar osteotomy site. And we repaired the annular ligament with a suture anchor. So this was the intraoperative X-rays with the forearm in supination, pronation, and neutral, and the radial head was quite stable once we had fixed the ulnar osteotomy site. We immobilized the child in full cast for a period of 4 to 5 weeks, and she has regained the full range of pronation, supination. This is almost 2 months post osteotomy, and she's doing quite fine. Post-operatively, she did not have any pin palsy as well. She has about 10 degrees of extension restriction, but apart from that, the child is doing quite fine. I'll just discuss a few acute Monteggia case examples. A few of them are quite recent, so apologies for any absent follow-up X-rays. So this is a 5-year-old who came to us with a Batter type 1. And we think a 5-year-old can probably get away with just a closed reduction, but we have seen a few of these, and sometimes the ulna gets really difficult to reduce. We had to do an open reduction of the ulnar fracture site, and we passed a TENS and an arthrogram to just reassess the radiocapitular alignment. This is 5 weeks post-op, and everything seems to be healing well. And this is an 8-year-old with, again, a Batter type 1. And we did a closed reduction of the ulna, and the radial head automatically fell in place. It was slightly unstable in pronation, but when we casted him in full supination, kept him on for 6 weeks, 5 weeks in the cast, and the follow-up X-ray was fine. I'm sorry, I couldn't find the follow-up X-rays for this child for some reason on our database, but I had seen him. And this is a Bardo type 3, and this is a 12-year-old girl. She came to us last week, and we got away with just a closed reduction of ulna, and the radial head fell back in its place. So that's a 1 week post-op X-ray follow-up. Thank you very much for the attention and allowing me to share my experience of Monteggia.
Thank you, ma'am. Thank you so much. Very nice presentation, and it's very informative. Anyone has questions?
Yeah, hi Suchitra. Enjoyed the presentation. Just a query about the suture anchors. It's like always there are many ways to do a thing, but if suture anchors are used, there could be a chance that sometimes you may either over tighten or slightly not have it as tight, or loosen the annular ligament repair. And most of us, I think, have really given up the annular ligament repair unless absolutely necessary in cases where we think that the radial head is slightly springy, not otherwise. We always start with opening the radiocapitular joint. We compulsorily remove the soft tissues. And after that, we find that it tends to sit down quite well once the ulnar length is restored.
Yeah.
So, any tips on how to make sure that you don't over tighten with when you're using a suture anchor, because you're going to end up drilling that into the ulnar bone?
True. I think the point where we are putting the suture anchor in, what I had noticed is where we tend to drill and fasten the suture anchor into ulnar. And the second thing is, it's best to do it in full supination, because that is the position where we are going to immobilize the foramen. And if we can get away with a full supination with suture anchor not feeling too tight, I think the child should be okay even after being immobilized.
Also think of is that when you're using a suture anchor, don't use it like a compression screw. Maybe better to think about it only like a unicortical good hold.
True. Yeah, true. Correct. Yeah. Agree with you.
Ma'am, we have few questions. How to cross correct and back line by Neha?
So I've shown it in my presentation. Basically, if you get a proper lateral view of the, let me just quickly go through that picture again so that it becomes clear. Give me a moment, please. Yeah, so basically, you try to align the proximal part of ulna with the distalmost part where you would expect the ulnar styler to be, and try to draw a straight line, because in anticipation that the posterior border is a straight line which does not have any gaps in it. So here in this X-ray, you can see if I have drawn the Mubarak line saying this is where probably the posterior border should lie. And if you compare it to where the actual posterior border is lying, it's about, and when I calculated, it was about 4.3 to 4.5 millimeters away from it. And what we would accept is probably less than 3 millimeters. And even a subtle variation of more than 2 millimeters has led to dislocation of the radial head. And the Storen's line is, we draw from the radial neck, the center of the radial neck, when it has to align with the capitulum in all the views, whether it's in flexion, extension, AP, lateral, doesn't matter. Well, the other question is, what's your post-op protocol when using suture anchors? There's nothing specific just because we have used a suture anchor. I think immobilizing in full supination for at least 5 to 6 weeks, letting the radial head stay in its place where it is supposed to, because the tendency, if we leave it in any other kind of position, would be for the radial head to go back where it calls itself its home. So other than that, there are no other specific protocols for forearm suture anchors in Monteggia. And is implant removal required for the case described? Well, when I was a fellow in Ganga, we used to routinely remove the implants, and because we have used a plate here, obviously I would tell the parents and the parents that we would be planning for removing the implant here. There is a huge trial that is going to probably start in UK, whether the upper limb implants, especially the 10 nails, would would need removal, but is there a need for another anesthetic to remove the tense nails? I think I would leave that to a single hospital's choice or a surgeon's choice. If you want to take it out, you can. If you don't want to, probably it's okay. But if it's a low limb tense, then yeah, better to get it removed.
Okay, any other questions? Ma'am, one question from my side. In acute cases, is it necessary, like orthogram is necessary every time, or you will do in any specific cases or any specific situation?
So there's one case that I showed where the radial head was kind of trying to slowly come out of the joint in full pronation. Sometimes it's best to have everything for sure when you have taken the child under anesthesia, do an arthrogram, evaluate the radiocapsular joint, be happy so that you can sleep fine. There's no harm in doing an arthrogram, but what if you come out of the theater and you suddenly think, oh, I should have probably done that? Then it's kind of hard to take the child back. And there's really no harm in doing an arthrogram. It's a simple 1-minute procedure. It just gives me that satisfaction that, okay, I'm able to see what I want to see and the way I want it to be. Yeah.
Vijay Bhaskar sir and THIMMA Reddy sir, anything to add, sir? Ma'am, any tips and tricks? Any specific?
Well, I think in whatever cases I have done, one thing I have noticed is don't hold yourself back to open the ulnar fracture. Don't struggle too much. Always in Ganga as well as in Sheffield, they told us the struggle time should be 20 minutes. If you go beyond that, then there is probably something that you will not be able to correct just by close reduction. I know that as pediatric orthopedic surgeons, it is a hard decision for us to open a fracture site. But in Monteggia, I think we can have a lesser threshold for that. Do an arthrogram and always do a pronation and supination check when you're in the theater to make sure that the radiocapsular joint is nice and stable after you have fixed the ulna. Also, I've just I don't know, Rujuta ma'am, if you agree with me, sometimes contouring the tense nail with an anterior apex to prevent posterior angulation of ulna or medial curvature in the tense to prevent subluxation can be slightly helpful. Depending on the angulation of ulna, you can probably contour the tense in an opposite way just to hold the fracture in its place.
Yeah, sure. So I think that's a good point that you brought out. When you're using a tense, essentially, unless the tense is used as a pair in a forearm, you don't get good interosseous tensioning. So at least maybe we are old timers, so we prefer a straight nail then. There is Dr. Carey from Bangladesh who has shown that even if you intentionally don't align the ulna, but you give it an angulation and you see to it that the length is restored, even if your K-wire or thick nail is passing a little oblique, that is completely fine as long as you have made sure that you've restored ulnar length and given the interosseous space good this thing. But yeah, with the tense, it's a good advantage to see which side the angulation is and then try to bend it in the opposite direction. Just try and use a thicker nail because if you're using tense, thin nails, they tend to be very rotationally unstable. And then definitely hypersupinate and hyperflex and maintain the 4 weeks of the immediate acute post-op in that position, while making sure that, of course, there's no compromise on the cubital nerve vasculature. So it's a good tip.
I think a lot of literature has also supported the fact that if we overcorrect the ulna when we are doing an ulnar osteotomy, it kind of helps. So, and we have noticed in a few cases that we have done as well. So don't be shy in overcorrecting the ulna if you need to be.
That's right. I
Ma'am,
think let's
one
move
more
on to the next
question.
one if there are no.
Yeah, ma'am, one more question.
Sure.
If you want to conserve a like type 1 Monteggia fracture, how is your protocol, weekly x-rays and all? If it gets displaced by 2 weeks or so, what you will do?
Yeah, I think as in any forearm, we would go for serial x-rays for the first 2 weeks. And if it does dislocate, then probably you're not able to maintain the length of ulna, and that's the only reason why the radial head is falling out of its place. So prepare the family always from the point that we see them that we're going to give a trial of conservative, but if it's not going to happen, then an MUA or plus or minus an internal fixation is something that should always be at the back of your head. Never overcommit in these cases.
Any questions? I think there are no questions. Thank you, ma'am. Thank you so much.
Thanks a lot. Thank you for the opportunity.
Yeah. Thank you so much. Now I would like to invite our TOSA president, Dr. THIMMA sir, to the session. Good evening, sir. We welcome you to the growth webinar too.
Yeah. So very good evening, respected senior madams and Santoshini and speakers. So just now I was hearing about the topic Monteggia. So really nice presentation by the Suchitra. And I think this is the second webinar going on.
Yes, sir. Yes, sir.
So good going and carry on like this and all the best. And
Yes,
thank you, especially seniors are also attending. I think
yes, sir.
yeah, really good discussion is going on. I came late, a little bit, sorry for that.
No
And
problem.
all the best.
Yes, sir. And I would like to thank you for your your presence and your team for the TOSA group Progress with Practical Skills and Fortifying Association. And you are putting a lot of efforts, like conducting monthly workshops and all. It is like a very nice initiative, and it will be helpful for the upcoming surgeons, sir.
Yeah,
Thank you, sir. Thank you so much.
That is the reason I want to start the practical, improving the practical skills in the juniors. So especially basics, I'm focusing, and glad to share that we had around 120 postgraduates and senior residents attended last program. And on this,
that's a good number.
Invite the all the guests and delegates for the next seminar and workshop on elbow fractures, and which should be on hands-on and principles especially. We are focusing on Yashoda, Gachibowli, high-tech city. So anyhow, I'll communicate with you all people.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much.
I hope the EC members also come for those meetings.
Yes, sir. Sure, sir.
Okay, and same time encourage the membership, this one. So we should increase the membership also. Anyhow, this is a very good presentation. Just now I was recollecting a good discussion. Good, I really got a few good points also. I learned from the talk. Thank you.
Thank you very much, sir. It means a lot coming from a senior like you.
Yeah, really. The few points are really interesting, and we should know those things actually. Okay, Suchitra.
Thank you, sir. Thank you so much. Okay, let us start with the second presentation by Dr. Sahithya Bandi. She has done her MS Ortho from Mehta Medical College, Khammam, and she has done her fellowship in hand and wrist and reconstructive microsurgery from Ganga Hospital, and she is now associate consultant in Apollo Hospital, Jubilee Hills, Hyderabad. And her topic for today is management of proximal interphalangeal joint fracture dislocation. Welcome, Sahithya, and please introduce yourself and start the session, please.
Yeah. Thank you, Santoshini, for giving me an opportunity to speak on this, for choosing me as a speaker. Thank you, Dr. Rujuta ma'am, and for creating this platform. Thank you, THIMMA Reddy sir. I'm going to start my presentation.
Santoshini,
Sir, sir.
one more thing I want to share you. Last time we had a discussion. You have separate session in TOSA Con.
Yes, sir. Yes, sir.
That day I discussed why you are separating, and you have separate session, and
Yes,
this
sir.
you want to incorporate in the main hall also.
Yes, sir.
Your group.
Yes, sir. Do you want it in main hall and second?
Yeah, that's what I'm discussing with the TOSA Con next organizers. So I hope and your group members will be opportunity to present in the main hall also.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much.
Santoshini, can I start my presentation?
Yeah. Please.
Yeah. Choosing a topic for post-graduation from a hand's injury was a little tough for me. So when I was during my post-graduation, when I was sent to a casualty to look after a polytrauma case, I usually used to look for long bone injuries, pelvic fractures, chest injury, head injury, manage everything, and just give a below elbow or above elbow slap for upper limb. I don't know what exactly happens post-operatively, like after the fracture has settled. So these were least concerned or neglected injuries. So good evening all. I'm Dr. Sahithya Bandi, Associate Consultant, Hand, Wrist Surgery and Reconstructive Microsurgery from Apollo Hospitals. The topic which I have chosen today is PIP, fracture dislocations. What are we going to learn from this talk? We are going to learn about the basic anatomy, how the PIP joint is formed. When a PIP joint fracture dislocation patients come to you, how do you evaluate them preoperatively? And what are the different types of fracture dislocations? How can you classify them? And later we'll deal about the management of the fractures and some of the interesting cases which we have managed in Apollo Hospital. Coming to anatomy. When you look at the PIP joint, it is formed by the head of the proximal phalanx and base of the middle phalanx. It is a hinge joint. And when you compare the distal joints with that of the PIP joints in hand, it has the largest motion arc, that is 0 to 120 degrees. This is a beautiful image, the first figure, showing the proximal phalanx. The ulnar and the radial condyles of the proximal phalanx are usually not of same length, or there is discrepancy between the condyles, because of which, upon doing complete range of movement at the PIP joint, a 9 degrees of supination occurs at the PIP joint. This is an image showing the formation of the proximal interphalangeal joint, the lateral supporting structures, that is the proper collateral ligament and the accessory collateral ligament, which forms the lateral stabilizing structures, whereas the volar stabilizing structure is by the volar plate, the blue structure. It further extends below onto the proximal phalanx as a checkerine ligament. So, to learn about the ligamentous structures supporting the PIP joint, the lateral structures which support are the collateral ligaments. The true collateral or the proper collateral take origin from the proximal phalanx radial aspect and gets inserted over the distal aspect of the middle phalanx. That is from bone to bone. When you consider the accessory collateral ligament, it takes origin from the lateral aspect of the proximal phalanx and inserts onto the volar plate. What exactly is the volar plate? It is a thick fibrocartilaginous structure forming the volar aspect of the PIP joint. How exactly it is located is, it is located over the volar aspect of the proximal interphalangeal joint, usually denser onto the distal insertion site and thinner onto the proximal insertion site. When you see distally, onto the radial aspect, it is more thicker because it takes, even the collaterals come and insert onto the volar plate. When it comes distal, proximally, it has a cord-like extensions called as the Chiranjeevi ligament. These cord-like extensions prevent hyperextension at the PIP joint. So, coming in total, what are the stabilizing structures? Volarly by the volar plate, the Chiranjeevi ligament, which prevent hyperextension at the PIP joint, and secondarily, it also stabilizes the lateral displacement. Laterally, the collateral ligaments form the stabilizing structures. And some part of bony stability is given by the volar base of the middle phalanx. Hence, the name given to this is as the ligament box complex. For displacement of the middle phalanx to occur, the ligament box complex must be disrupted in at least 2 different planes. So when a patient presents to you for evaluation in preoperatively, ask for the mechanism of injury, whether it is a direct injury, direct impact injury onto the index finger or any other digits caused by cricket ball injury, or it could be a direct sliding injury. Patient directly falls onto his digit, resulting in avulsion type of injuries. When it comes to clinical examination, look for swelling of the digits. Where exactly the swelling is located. Look for the tender spots. Is it volarly or dorsally? If it is volar, you can think that it could be a volar plate injury. If it is dorsal, it could be due to central slip injuries. Look for any ecchymosis and check for deformity. When you see the second video, when the patient is attempting to flex the finger or make a hand grip, there is crossing over of ring finger over the little finger. And see how the digit is ulnarly deviated. So these all are the things to look after. So whenever a fracture dislocation or a dislocation of PIP joint presents to you, try to reduce it. Never give a axial traction, because axial traction upon trying to reduce it may cause entrapment of the volar plate within the joint space. And it causes, it impacts the reduction of the joint. So once you have reduced the joint, check for the stability of the joint, both by asking the patient to actively flex the PIP joint and also by yourself flexing the PIP joint. Also check for the integrity of the important structures present volarly. There is a volar plate. Laterally, check for the tenderness, whether there is any collateral ligament injury, and posteriorly check for the central slip injuries. After evaluating preoperatively, the next thing which we have to do is advising imaging. Whenever a hand fracture comes to you, the basic X-ray which we write is the AP view and oblique view. So when you look at the first X-ray, that is the anteroposterior view of a hand, you can easily see the fracture site. There is fracture of the middle phalanx of the middle finger. The joint space is also reduced. When you look in the oblique view, you couldn't identify anything. So the importance of lateral view comes here. It is important to take a dead lateral or a true lateral view of a small joints. See, in dead lateral or a true lateral view, you can easily identify the fracture. And in lateral view, you should also look for the V sign. This sign indicates that there is dorsal displacement or dorsal subluxation result because of the fracture dislocations. Coming to types, how do you classify PIP fracture dislocations? You can classify based on the presence of the distal fragment. Like if it is present volarly, it is called as volar fracture dislocation. If it is present dorsally, it is called as dorsal fracture dislocation. If it present laterally, it is called as bayonet type. When the impact occurs like on the tip of the finger, like axial loading, it results in pylon type of fracture dislocations. So these are based on the displacement of the distal fragments. It can also be classified based on the amount of articular surface involved and also the stability of the joint. So when it is less than 30 degrees, it is a stable type of fracture. 30 to 50 degrees is mid. If it is more than 50 degrees, it is usually unstable fracture dislocation. So when in order to reduce the fracture, you need to maintain the finger PIP joint in flexion. If the amount of flexion required to maintain stability of the joint is more than 30 degrees, it is considered as unstable fracture. Coming to the management, the ultimate determinant of treatment is whether the joint remains concentrically reduced with active motion. We have to look at the articular surface involvement, amount of articular surface involvement, whether it is 30%, 30 to 50%, or more than 50%. And check for the degree of flexion needed to maintain the joint reduced. Coming to different treatment modalities. When it is unstable fracture, you go for operative modalities. When it is stable fracture, you usually go for non-operative modalities. Stable, undisplaced fractures can be managed by buddy strapping or neighbor strapping with the opposite digit. Or you can give a extension block splint by maintaining PIP joint in 10 to 20 degrees of flexion. You can give an extension block splint. Coming to operative modes, there are different operative modes depending upon the fracture fragment. You can go ahead with screw fixation or a K-wire fixation, or you can go with extension block wire fixation. There are certain traction devices like static traction and a dynamic traction devices, or directly you can go with arthroplasty. Coming to extension block fixation, extension block wire fixation. Usually, when the patient is not satisfied with splint, you usually go with extension block wire fixation. This is a case which presented to us with two different fragments, displaced fracture. Upon doing flexion, the fracture was reducing, but the joint was not stable. So what we have done was, after making PIP joint into flexion, we have passed a K-wire into the proximal phalanx head in order to stabilize it, as extension was causing displacement at the fracture site. This was a final picture. Another patient who presented with swelling at the PIP joint level, unable to flex the PIP joint. It was very stiff. And this was his X-ray, showing a fracture displacement, dorsal dislocation of the PIP fracture. So what we have done was, we have given a screw fixation. There was two large fragments, which was fixed with mini lag screws. And then fluoroscopically, it was checked whether the joint congruity is good and it is not subluxating or dislocating. This is the 4-month post-op. When the patient has come, the range of movement at the PIP joint was functionally acceptable. Coming to traction devices. This is a patient who presented to us with volar chip fracture of the middle phalanx base. So we have given him a THIMMA splint. It is a static traction device. It is a by using the aluminum plates, we usually bend the aluminum plates by keeping wrist in slight dorsiflexion, MCPs in flexion, and the traction is achieved by passing a suture material, one suture, one prolin from the nail. This is how we give traction at the fracture site. And we incorporate this aluminum splint within the POP. This is how the joint is maintained. Joint space is maintained and the fracture is also reduced. It is a static device. For about 2 to 3 weeks, the fracture ends become sticky. Later, we cut the suture and check the finger under the radiograph. This is the final follow. Coming to dynamic traction devices, what we use is the Suzuki frame device. It is nothing but like the ligamentotaxis, where we use in distal radius fractures to achieve joint and fracture reduction by using K-wires. It is an excellent device, easier, less expensive, and most effective. We just use K-wires, and these are the dental rubber bands to achieve traction at the joint and achieve reduction at the fracture site. The frame is constructed by using K-wires. Here we need to have a longer K-wire and a shorter K-wire. Additional third K-wire also can be passed to correct the displacement or subluxation. Coming to arthroplasty, we have hemi-hamate arthroplasty, which was introduced in 1999 by Hudson. Usually, the middle phalanx base matches the hamate bone, the carpal bone. So, a patient presented to us with comminuted fracture of the middle phalanx base. So, we have taken him for hemi-hamate arthroplasty. This is an incision given. A mid-axial incision is given and distal ends of the mid-axial incision is extended obliquely. The flap is elevated and what we see is the flexor tendon sheath. Between A2 and A4 pulley, the sheath is incised. In order to look the congruity or status of the joint of the PIP joint, it has to be done in a hyperextension. That is the shotgun approach. Like a shotgun, we open up the PIP joint by doing hyperextension. After doing that, we look for the status of the middle phalanx base and excise the amount of damaged middle phalanx. Later, we measure the defect, both the radio-ulnar and the anteroposterior defect. The same amount of, after measuring the defect, the same amount of bone is harvested from the hamate. This is how the harvested hamate is fixed onto the middle phalanx and secured with screw, mini lag screws. So this is a fluoroscopic image showing the defect after excising the injured middle phalanx base. This is a fluoroscopic image showing the hamate bone fixed into the defect using a mini lag screws. Next comes the volar plate arthroplasty, other modality of treatment in case of middle phalanx fracture base. A sketch showing the volar aspect of the PIP joint. This is the volar plate, the A4 and the A2 pulley. the flexor tendons and the neurovascular structures are retracted. What exactly is volar plate arthroplasty is? We interpose the volar plate into the PIP joint. So this is how the volar plate is detached from its distal insertion. Simultaneously, you have to excise the amount of damaged middle phalanx base. After that, the volar plate is passed into the trough created in the middle phalanx base by using a pull-out suture technique. This is how the sutures are passed from the trough into the dorsum of the middle phalanx, and it is secured onto the dorsum by a button. It is an excellent pain relief method with giving good range of motion. This is a patient who presented to us with stiffness of the PIP joint. So similar to the hemihamate arthroplasty, we have raised the flap, we have retracted the flexor tendon, and the volar plate has been detached from the distal insertion site. After detaching, the volar plate is secured with ethibond suture, and this is the looped K-wire through which the suture was passed onto the dorsum of the middle phalanx and secured using a button. This is a final fluoroscopic image. So this is the final flow chart showing how exactly we need to manage PIP fracture dislocations. The main important thing we have to look after is whether the joint is stable or unstable after reducing the fracture. Thank you.
Any question?
Very nice. Sahithya, what is
Thank
the
you,
other option if you know the volar plate is all shriveled off and you can't really do that? Is there any role of any fillers or tissue glue you think which can be used as an interposition?
We can use flexor tendon, ma'am. FDS single slip can be used. Initially, it was used.
Yeah, thank you.
Any questions? Sahithya, I have a question for you.
Yeah.
Like if it is like 4 weeks old fracture dislocation or so, what is your approach? Like do we need to try fixation or we have to go directly to volar plate or hamate graft?
Look for the status of the joint first. How is the range of movement? If it is functionally acceptable, no need to go for any procedure, just go for physiotherapy. Even it is 4 weeks, we can go ahead with surgery. Depending upon the amount of articular surface involvement. So if it is comminuted, small fragments, you can go with hemihamate. Directly replace the injured site with the new bone. If it is less than 40% involvement of the articular surface, you can try with volar plate arthroplasty.
Any questions? I think no more questions. Thank you, Sahithya. It was very detailed and informative presentation.
Thank you.
Rujuta ma'am, you would like to add any points?
No, I think she's really covered the topic very nicely. So.
Yes. Sir, anything from sir? Vijay Bhaskar sir, THIMMA Reddy sir, anything from your side? I think no one has any questions.
Ma'am, I have one question, ma'am, for
Yeah.
Dr. Sahithya, ma'am. Ma'am, you have explained in your presentation about the Zimmer splint.
Yes, yes.
So when you're passing the suture through the nail, for how long that traction is maintained, ma'am? And what size of proline is used?
One proline is used, ma. Usually we maintain it till the fracture ends are sticky. It is at 2 to 3 weeks.
Okay.
At 3 weeks, we cut the suture. We maintain it in the splint. We ask the patient to start mobilization.
Okay. Okay, ma'am. Thank you.
Okay, we can conclude the session. Ma'am, any message for the girls? Rujuta ma'am, from your side?
I think it's very nice to see the growth of the growth itself.
Yes.
And I think what you all really need to come together is keep on discussing amongst yourselves the challenging questions. Make sure that you kind of identify how many girls are there in every branch and start creating more and more avenues for bonding together. So like what we did on this this Women's Day, because I suddenly realized that there are more than 4 ladies in spine, which is a unknown so far. You know, it was thought even amongst orthopedics, it was thought that this is one place where women will never enter. So, but surely and strongly we have been there too now. So accordingly, every branch of ortho, we should be able to identify the expertise so that in future we can mentor the juniors who are inclined towards them. And that way our academic presence will grow stronger, because I think finally it's all about the subject and less about the gender. So congratulations.
Thank you, ma'am. Thank you so much. And we are very much thankful for your presence in this session. Thank you so much for your work, ma'am.
Pleasure. Thank you.
Yeah, ma'am. Thank you, THIMMA Reddy sir and Bhaskar sir, for your presence in the growth webinar and giving me your time. I think we can conclude, ma'am. Anything, girls, you want to discuss anything? Okay. Thank you so much, Suchitra ma'am and Sahithya, for accepting the invitation for the webinar as speakers. Thank you so much, ma'am.
Thank you, Santoshini. Actually, I'm truly grateful for the opportunity, and I completely agree with what Rujuta ma'am said. The more we discuss the subject, I think more familiarized we become with the other specialities, and it would be easy for us to help the junior colleagues also pick up a field of their interest. So I think mentoring should be taken seriously. It would be quite helpful.
Yeah. Okay, ma'am. Thank you. Thank you so much. Thank you so much, everyone, for attending the webinar.
Thank you so much, ma'am.
Thank you, sir, for coordinating the session. And we'll conclude the session now then. Thank you. Bye, everyone.
Thank you, ma'am.